welcome, and we'd like to call to order the meeting of the Rutherford County Benefits and Insurance Committee. And you have before you a copy of the minutes of the last meeting. First, we need to approve those minutes. Do we have a motion? Ms. Barnes, do you have a second? Ms. Hickerson, did anyone have any corrections or additions? If not, all of you in favor of that, please say aye. Okay, thank you very much. All right, next on the workers' comp and OJ, no, excuse me, I'm going too fast. We're ready for the financial report from Mrs. Street.
Good afternoon. We'll begin with Fund 264. Fund 264 for the month of February ended on a medical basis of $788.82 per employee per month, compared to same time of last year of $788.74, for a year-to-date average of $879.75 compared to prior year of $853. When we combine the on-site medical experience with our self-funded claim, our per employee per month insurance plan cost increases to $819 compared to prior year of $825, for a year-to-date average of $908 compared to prior year-to-date average of $888. For Fund 266, we ended the month of February at $445,613 compared to the prior year of $1,126,881.
Do you have any questions regarding this report? The trends look basically favorable, do they not?
Yes, sir, that's correct.
All right, if there are no other questions or comments on that. Back to the wellness update. Ms. Perrion is not here with us today, so we're just distributing for your review her report, and you have that, I think, before them. Is that?
Yes, sir, it is. It's right behind Mr. Good's report.
Okay. So, Mr. Good, I started to start with you first, and I skipped right over you, didn't I? But anyway, Mrs. Perrion's report is in there, so I've already made mention of that. So, Mr. Good, you can tell us about workers' comp and OJI statistics.
Thank you. I'd like to report in the month of February that we had 20 injuries requiring medical attention. You can see the breakout there. The biggest category for that is going to be slip, trips, and falls, basically due to the weather this past month of February. Remind you that the county offices were closed for 2 days during that time period. In addition to that, the school system was closed for an entire week because of the weather. Even during that time when the county offices are closed, there's certain offices that are required to maintain vigilance during that period, being the Sheriff's Department, the Ambulance Service, Juvenile Detention Center, the Correctional Work Center, and the Fire Department. All still has to have people in working on those days when the county was closed, so we incurred some injuries during that due to the weather. That brings the total for the year to 34. As you can see there, the recordables are 22 for the year. 8 had restricted days, 8 lost days, and 6 all others. If you look at the next graph, you'll see where we are this year as compared to the 2 previous years. And again, the reason for that spike this past February is because of the weather. The dollars incurred for those 20 injuries is up also, again, because of the weather being severe. It's $78,787. 8 of those injuries were with the Board of Education, and total dollars incurred for those 8 was $31,845. The county general had a total of 12, and it was just under $47,000. And you can see that within the county general, where those injuries occurred, 9 of the 12 were with the Sheriff's Department. And again, Sheriff's Department was out on those 2 days when the county offices were closed in weather conditions. And because right now some of those injuries are still open, they haven't settled out, the total dollars incurred, as you look at the last page, you can see the huge spike there for the dollars incurred for that time period.
Okay, do you have any questions for Mr. Good? If not, then we thank you for that report.
Thank you very much.
Next, we have a report. The title of that is Your Health First, and we're going to hear from Amy Summerlin from Cigna to give us a review of that.
This is the fourth quarter results for the wellness programs, the lifestyle coaching, and chronic coaching. So chronic coaching, you'll see that the current, which is October 2014 to December 2014, was up 16.5%. So that's great. That, it was 16.5% compared to the base of 20.1%. Lifestyle coaching was up 7.3% compared to 5%. The wellness coaching was increased to 19% over the base, which is 17.4%. And then the treatment decision support was 2.8%, and the base was 4.3%. So the lifestyle coaching and the wellness coaching are up, so that's good. We're getting people engaged. This is just a snapshot of the top chronic conditions that the employee population has. So I kind of highlighted the top four. You'll see the top four are depression, diabetes, osteoarthritis, and weight complications. So hopefully we'll see those numbers go down as we continue the wellness program. But just wanted you guys to know kind of that's the areas we'll try to focus on and try to hit so we can decrease those. If you'll flip to the next page, this is, again, some more numbers on the coaching. You'll see for the lifestyle coaching, we had 947 people enrolled.
Ms. Harvey?
Just a quick question. If you have a person that has multiple, are they counted twice, or how many categories they fit into?
Under the conditions.
Or do you rank it by the most severe and just count them as one?
Probably be counted in each category that they fall under. So there could be a few people in each bucket.
Okay, if on chronic conditions, you say our current percentage is 16.5 compared to the base of 20.1. Are we doing better or worse? Okay. And we have a few more people in lifestyle coaching, so that is better. Is that correct? Okay. And wellness coaching as well. Okay. Other comments or questions from Ms. Summerlin? Okay, then thank you very much. Mr. Brown, you're going to tell us with Cowan Benefits is going to start with a health plan cost survey before we get into our own specific discussions, I suppose. So go ahead and proceed, Mr. Brown.
All right, I'm going to do it from over here so I can manage the computer, but you guys should have a copy of this presentation available. I have made a couple tweaks on the PowerPoint up here just so you can follow along a little bit better, made the highlights and things, but the goal today is really to kind of give you an overview of how your plan compares to some of the other Kaiser and Mercer database surveys we have available to us, as well as a couple other municipalities in the area. So what we thought we'd start off doing is looking at your rates, the gross rates, your employee contributions, and your plan designs, and then some other trends in the insurance industry. I don't want to go through every slide, but as we said, this will kind of help us as we lead into, I believe, the medical part of our renewal discussion. And so as you kind of go through here, on the very first page, page 2, it says, a couple of points that I highlighted on the above is over the past 3 years, employers offering consumer-directed health plans have risen from 17% to 23%. So over the past few years, you guys have had the HRA plan in place, but the enrollment has continued to increase into that plan. As we get into some of the renewal discussions later, you'll see we almost are to the point where we have about a third of the employees enrolled in each of the three plans. So that's kind of how we stack up compared to that. And then on average, premiums for high deductible health plans with a savings options are lower than the overall cost for other type plans. And so some of the things that we provided that we might get into when we talk about the medical is we're seeing the same thing with our plan. Our per employee per month claim utilization in the consumer-driven HRA plan is pretty significantly lower than the other two options. And so we've got some things we can talk about that as we get into there, but our statistics are kind of lining up with that option. And then another thing we really will probably definitely spend a lot of time on a little bit later is in 2013, employees on average contributed 18% of the health insurance premiums for single coverage and 29% of the total for family. So we'll kind of look through that. I have the statistic from this Mercer-Kaiser data that's a little old. I mean, it's updated each year, but this is most recent. But then we do have some other municipalities in the area that we'll compare some of those contribution percentages to see how they stack up to ours. The next slide on slide 3, the only thing I really brought out of that one is really the first one. The average monthly premiums for single PPO coverage for 2014 was around $518. For family is $1,444. When we get into, I actually have these numbers on a chart in a second where you'll see how your numbers stack up to some of these averages, but I just want to kind of point that out so we don't skip over a slide. And I'm going to skip a couple of these really in essence of time because I want to make sure we have a lot of time on the back end, but really where the details get in is on slide 6 of how your plans compare to some of the survey benchmarks. And where my slide's a little different is I did go ahead and I have employers 200 and above, so large employers. Some of the slides will be a little different there. Government entities, employers in the South. Those are kind of the three benchmarkings from the Kaiser data. And then we looked at our population in this area, and I pulled out a couple municipalities, and one's Company A, one's Company B, and then your data's at the bottom. And so I put in Rutherford County, and then as you guys are familiar, instead of the options 1, 2, 3, option 1's the copay plan, option 2's the deductible, and option 3's the HRA. So I have that on the big screen. That was one of the changes I made. But then as we look over at the numbers, as I was kind of showing in that last slide, these are your insurance premiums. So we spent a lot of times the last few years looking at employee contributions and the county budget. This is that total insurance number for individuals, which is single coverage, and then family. So they really don't break out the benchmarking data for employee, child, or spouse. So we look at it just from an individual and family perspective. And as we kind of go through some of the plan designs, your copay plan and your deductible plan, somewhere probably in the middle of there would be kind of the average plan design. So what you might say is, I see that government entities on average, it's $530 in the blue. Make sure yours is blue too. $1,317 for families, and then our plan is right there, $513 or $590. And kind of as I'm looking through between what our deductibles are, what our copays are, and as you'll see in a couple slides later, kind of what the average deductible and copay is, that plan's kind of in the middle of those two options. And so if you look at it that way, our plans from a gross insurance premium basis are in line with a lot of the parameters at the top. And then if you look at companies A and B, for example, a lot of times that option 2 is their version of an HRA or a high deductible health plan, their consumerism product, and you can see ours is priced a little bit lower at $372 versus $496 or $429, and then for family coverage as well. So really when I look at this slide, I see that honestly on average our gross rates are in line with other municipalities, other employer groups. What we get into where we usually spend a lot of time is on employee contributions. And so what we show on this slide is what's the average employee contribution for larger employers, for government entities for the South, those same two kind of sample groups that we used, and then the Rutherford County data. And this is pretty similar as what we've shown in the past. I know Ms. Street did something a couple years ago showing about 10 different municipalities, city groups in the general area in Middle Tennessee. And this one's kind of showing the same where The Rutherford County plans, on average, the employees do pay as a percentage less for single coverage and in family coverage in almost every other data point on this particular slide. And that's something that's going to come up, I think, as we get into the renewal discussions a little bit later. So I show it as a percentage because we're kind of locked in as the employees pay 10%, the families pay 14%, and we adjust that usually 1% a year. So those numbers might be familiar, but what the next slide shows is really probably what the employee sees is what's the actual dollar, what's coming out of my paycheck, what do I pay a month for premium? And everything's based on the 12-month cycle. So just so some of you guys know, it's not the 10-month, it's the full 12-month cycle. And so the copay plan, the deductible plan, HRA, it kind of ties with the contribution percentages as you go down through each one of those columns that the Rutherford County employees for single coverage and in most all instances for family coverage do pay less than some of the other benchmarks. You guys stop me too if you, I mean, it's going to be somewhat, if you have some questions, because I do have about probably 8 or 9 more slides, so I hate for you to hold your questions to the end if you have something. Then we get into kind of plan design. So the next few slides are about plan designs, and then I have 2 or 3 on some trends, and then we'll kind of get into the renewal. But this is plan design. So I was saying before, you can see the blue section, kind of that middle section, and then your information at the bottom. Looking at your deductibles, your deductible ranges from the copay plan being $1,000, the deductible plan being $500, and then $2,000, $1,000 for your family, how that compares to some of the other plans. So, when I look down through there, you can see most of the municipalities still have a $500 plan option available. I'll be honest, most of my other sectors do not. I mean, most of my other plans are now starting out at $1,000 deductibles as kind of their base plan. But as we're looking here at municipalities and other government entities, they still, as we all know, offer a little richer benefit than some of the other sectors. So you're in line there. The HRA plan, you guys have a $1,750 deductible. Now, the county does give employees money to help them towards that deductible. But on average, I know Company A, option 2 is also an HRA plan. So you can kind of see with that one that your deductible is a touch higher than theirs. But in general, your deductibles are in line with the other kind of benchmarkings we're looking at.
On Company A, do they actually contribute the $1,500? Because even though we're higher at $1,750, we are contributing $1,500 towards that deductible. So can you speak to that, or do you know?
They contribute $500 and $1,000. So at the end of the day, in both instances, the employee's responsible for $1,000. You guys contribute $750, they contribute $500. Good question. As far as the out-of-pocket maximum, so a lot of times when we're out doing the meetings with employees during annual enrollment time, we focus more on what's your worst-case scenario. So even though the deductible is important, really what I like to know is what's the out-of-pocket maximum, kind of what's my worst-case scenario. And as you can see here, to that point, your out-of-pocket maximums as we go down through that list is a little higher than the averages. And so I'll just be honest, as we're kind of painting a picture here, we are getting a little bit higher increase than we would like. And so we've looked at plan design changes and contribution changes and a lot of different options. But you'll see is what I'm wanting you guys to kind of see through these plan design sections is your benefits are in line, if not a little bit higher out of pockets. Copays are a little bit in line too. So, I mean, when we look at this, where you want to know how do we stack up with others, your plan design's in line, if not a little bit higher deductibles and out of pockets than some of the others. What we're also seeing is your contributions is a little bit richer. So again, that where you want to make sure you're kind of keeping it par with others, if that's what you're, it's a benchmark for you too. The other thing we looked at is the coinsurance. So what that means is you normally have to meet a deductible, and then once you meet your deductible, the insurance kicks in. They pay a portion, you pay a portion. And in most of our plans, the 2 PPO plans, copay and deductible, the employer kicks, or the insurance company kicks in and pays $80. The employee pays $20 after the deductible, and in the HRA, it's 10%. And almost across the board, and almost all my clients, most of them are still at an 80% type plan. Some of them have had to move to where the employee pays 30% over the last couple of years. But for the most part, this slide is pretty consistent amongst all groups we work with. Copays. So with your plan, really the main plan you have is a copay PPO plan that has copays available for office visits and things like that. And you can kind of see there when you're comparing against the other sectors and the other clients, under that copay plan, yours is a $30 copay for primary care, $50 for specialists. That's what the 30/50 means. And still, we're looking at some of the others are in that $20, $25 range, $25, $40 for specialists.
I believe the state and Mr. Huffman, they're at 35 and 50, is that correct? I think so as well.
And then the last slide I believe I have on plan design is the pharmacy. So there's a lot of numbers on here, but essentially with your PPO type plans, you have a $5 generic, $30 middle tier drug, and $60 is the third tier drugs. It's a $5, $30, $60. And as you look across, that's pretty average, and we actually have a $5 to try to promote generics, so it's not a bad thing that our number's a little lower than the 10. That was intentional because we all know that the more generic utilization, the better for our claims. So that was actually, this slide's pretty on par with everybody else. Now, the couple other things, I'm going to skip a couple slides because I don't want to focus on this the whole session, but a couple other slides that we did point out, dental, flexible spending account, those things are pretty normal. The slide 17 talks about the consumer-driven healthcare, so your HRA plan, really all this is just showing is all the way back to 2008 to 2014, the number of employer groups, the number of employees in those plans have continued to increase through the years. So you guys have seen that. And we are seeing with our clients more kind of cost measures to drive employees into those consumerism plans. So this data, honestly, this data is 2014 data. Some of it's 13 data. This last renewal cycle, January of this last year, we saw a lot of changes. So this is a little like a year-old data, but a lot happened last year that's not told here, and I think that'll be some things that your consultant will talk to as we get into some of your more real-time decisions you have to make today when we get to the medical dental vision renewals. The last couple slides to show wellness. We've talked a lot about wellness, but you can kind of look at those on your own. All this is really showing is that more and more employers are going towards wellness programs, as going to incentive-based wellness programs, and you guys are definitely on par, ahead of the curve, definitely in that area. And then kind of the last couple slides that are going to lead into some recommendations we have today are starting on slide 20 and 21 about spousal coverage. And so as we start talking about employee contributions and who we offer coverage to, what we are seeing a little bit more of a migration to in the last couple years, and a lot more this last renewal that's not shown in this data is increasing more cost to spouses, having what's called spouse opt-out programs. We talked about this last year, but because we had a very low rate increase, pretty much a rate pass last year, this wasn't something we wanted to consider, but something we do want to bring back to the table this year. And as you can see, under this slide, it's kind of low. Government entities, employers that will not cover spouses, employers that require spousal surcharges are low. But I would imagine probably if we looked at last fall's data, the municipalities, government entities that are on a 1-1 cycle from last year, several of my clients moved to different forms of this type of arrangement this past 1-1 that's not showing up here. So we'll talk about that. This slide actually talks about it in more. So what types of defined contribution approaches, that's something else maybe a lot of you've heard of, is we're just going to offer employees X amount of dollars and let them decide how they want to select their benefits. And so this slide shows large employers, government entities, employers in the South. And something we're going to be talking about today is the one I've highlighted in blue is contributing the same amount for all plans and then allowing employees to pick which plan they want. We did some discussion about giving employees just a set X amount of dollars, but really with most of our clients, that's hard to say. If you give everybody $500 and your families pay $1,500 today, that means their cost is going to go up 3 times. And so as much as we have a lot of discussion with all of our clients around defined contribution approach, what we're seeing more likely is offering the same amount for one plan and letting everybody buy up, or offering where you give a certain amount for employees, spouse, and family. And so this one here that's highlighted in blue, as you can see for government, has pretty much the highest percentage from 2013 other than not considering defined contribution. So I would probably expect those numbers to have doubled last year, but this is 2013 Mercer data. And so with that, I believe that this last one's on some private exchanges. That's something we could kind of talk about down the road, but really those last couple ones is what I want to focus on, unless anyone else has any questions before we get into the renewal.
Okay, so Mr. Brown has given us a large array of information here. Does anyone have any questions about this? So, well, let's see if Ms. Street was listening. What's your summary of what he has told us here?
In short, it appears that we are in line in terms of premiums and plan offerings. Our contributions are still running 5 to, in some instances, 20% less, depending on the plan and tier, than what we see in some other government entities. Some of the recommendations that we've developed are supported by the study that was completed by these two organizations. As Mr. Brown said, we'll be talking about the spouses as well as a defined contribution model today. So I think all in all, we are moving in the right direction that's consistent with some of the other governments.
Okay, anyone want to make any other further comments before we move on into our Mr. Sandvig?
Personnel group, and the teacher plans around us in Tennessee, we see a lot of the same things. Now, there are a few that charge no charge for the employee, like we do for the HRA plan, but we saw significantly higher employee pay for family coverage, family and spouse coverage, than we
You're
have.
just sort of reaffirming the fact that we are certainly in line, and somewhat the premiums are less in any number of cases. Okay, so that being said, are we ready to move on for the first agenda item 7, which is 2016 stop loss renewal?
In your packets,
Forward with that.
I've tried to provide some resource information for you in conjunction with the recommendation so that you can refer to it as needed for each of the renewal categories. And beginning with the stop loss premiums, I provided you a 5-year look back with the cumulative period to show you what our premiums, paid claims, and paid loss ratio has been over the last 5. And what you will see or derive at in looking at this is beginning in 2010 through 2012, we had a loss ratio that took a turn in 2013 where we had a negative loss ratio. Again, in 2014, which is only really 6 months of our fiscal year, we have a 0 paid loss ratio, which gives us a 5-year cumulative of 106.9%. So what does that mean? It means that we paid in less than what they paid out, in essence, right? If you will go to the second sheet, this is the proposed renewal that was provided to us by Cigna. Our current individual pooling level is $750,000 with a composite monthly rate of $6.55 per employee. To remain at the same pooling level, our rate would increase from $6.55 to $7.21. Now, given the fact that we've had 2 positive years, you may want to look at option 2, which increases the individual pooling level to $825,000 with a composite monthly rate of $5.98. My recommendation to the committee would be this. When we moved to $750,000, we had had several really good years. And that is why we made the decision to go to $750,000. If you look at the last 2 years, you would say that was the right decision. The years prior to that says that we just were on the bell curve and didn't realize it at the time that we made that decision. My recommendation would be that we hold 1 more year at the $750,000 to see what our trend line continues to look at, and to take the rate increase of $7.21 and revisit it next year. But of course, that is for the committee to decide and vote upon.
Mr. Sandvig. All right. A motion to approve. Do you have a second? All right, Ms. Boney. Now, further discussion. So some of you are quicker at understanding all of this than I am, I'm sure. So 2011 and 12, the paid claims were almost three times as much as we actually paid in premiums. Is that correct?
Yes, sir, that is correct. And by paid claims, that would be the portion of the claim in which they paid above the pooling level of $750,000 on an individual level.
That was substantial. So in 2013, we had a much better year, you might say, as far as paid claims.
Correct. Mr. Hester has a comment, sir.
Oh, Mr. Hester, excuse me.
Yes. If we made the assumption that the option 2 proposal was in place in the years 11 and 12, do you have any statistics as to how those paid claim numbers would have changed?
I don't, because I don't know what number of claims are represented inside of the paid claims in order to be able to make that calculation right here. You know, if you made the assumption it was one claim, that would be an easy calculation, but I would need to see how many claims are over the pooling level in order to determine the premium to loss ratio.
Okay, further questions or discussion? We do have a motion and a second to go with option 1 and stay with the $750,000 pooling level one more year. Is that correct?
Yes, that's correct.
Anyone else have a comment or question? If not, then you're ready to vote. All of you in favor of that, please say aye. Aye. Are there any opposed? Did anyone say no? Or I don't think so. All right, thank you then. So that's takes care of that. Next, let's discuss 2016 dental insurance rates.
I provided for you as a resource document a two-sided page which shows you option 1, 2, and the buy-up plan, which is on the back of the page, and it shows you what our experience has been in terms of rate increases year over year, beginning in 2011 to 12, 12 to 13, 13 to 14, and 14 to 15. We began offering the buy-up plan in 2013, and what that plan does is it takes the orthodontia benefit only from $1,000 to $2,500. If you'll go to the second page, which has been provided, which is the recommendation for the increases, you will see that we are recommending an increase of, and this would be 12-month deductions. County General, of course, we would take the 10-month adjustment for Board of Education. For option 1, a single increase of $1.50 a month, a family increase of $4.66, a single increase of $4.04 on the buy-up option per month, with a family increase per month of $12.57. For option 2, the single rate would go up $2.46 per month, and the family rate would go up $7.66 per month. The reason that you are seeing a much higher premium on the buy-up option is because we have a high utilization and some adverse selection against that plan. Next year, if the adverse selection continues, we may be in a situation to discuss whether or not it's feasible to continue to offer that plan to employees when we look at a premium versus pay ratio. One of the things that we are noting and that we have attempted to educate employees on year over year since this plan has come in through the open enrollment process is about the utilization of the orthodontia benefit. What we're seeing in that plan is that people are paying the additional premium, and then they're making bad choices about using in-network versus out-of-network. So they're paying more premium to get the higher benefit, and then they're going out of network, and they're reducing the actual pay amount that's coming to them from purchasing that benefit. Now, had everybody used in-network, they would have had a greater savings, and we would see a different type of renewal potentially as well. So we'll continue to educate employees on that. But this is the recommendation to the committee. The second sheet is standard of what you typically see. I just try to simplify information for you, knowing we had a lot to go through today. And it will show you the breakdown of what the county portion is and the employee portion as you typically would see.
Okay, again, we've got a wealth of information here from which, and the proposal is You've seen that on that first page where it shows what the employee rate increase is, and you can see what the current rate is. For example, single rate 2015 is 1875, and that's going to 2025. Is that correct? For 2016. So I was just looking. So you have that little table on the second
Yes,
page.
that's correct, sir.
And those are per month increases. Give you a bit of time to look at that and see if you have questions or any questions of Mrs. Street? What's your wishes with respect to this recommendation?
Motion to approve the recommended increase on the dental rates for 2016.
Okay, we have a motion. Do we have a second? Mr. Sandvik. And how many people do we have participating? Do you know that number, Mrs. Street?
Last time that I looked, it was, well, it's on our report. Let me see. Thank you. For the month of February, we were at 4,162.
Those are employees that are participating?
Yes, sir, that's correct.
Quite a large number, isn't it? High percentage. So it must be working to some degree. Mrs. Barnes?
For adding additional dental offices to this plan, so there'll be an option, whether in a one or two? I mean, I hear that question a lot that comes from employees.
What is the option of the network for the dental? Can we ask Mr. Huffman to come up and talk about how they network for the dental? He would be the
Mr.
appropriate
Huffman,
person.
please come forward.
Every year, we run a report of the out-of-network dentists that are utilized by the Rutherford County population, and then we have a provider contracting recruiter reach out to these dentists and try to get them in the network. So we do that periodically. It comes down to a conversation of, are you willing to accept this reimbursement or not? Yes or no. If so, then we can add them to the network. So that's a constant process. If there's, and we always start with the highly utilized ones, at the top of the list and kind of go down. So we have some repeat ones that we've contacted that have no interest, obviously, but we've had a huge success of adding dentists over the years. Mm-hmm.
Thank you. Any further questions or discussion? We have a motion to accept the proposal with respect to the rate increases on dental services. If there are no more other questions, then we're ready to vote. All of you in favor of this, please say aye. Aye. Are there any opposed? All right, thank you very much. Next, let's review 2016 vision insurance rates.
So last year, if you recall, we did not take a rate increase on the medical, but we did carve out vision to be a standalone benefit that's 100% paid by the employees. When we did that, 1,000 employees elected to not take vision coverage. Of the 1,000, 700 of those comprised of family units, which we obtain more premium through a family unit, obviously, than a single or a single plus child. As a result of that, we need a rate increase this year to offset the 1,000 people that elected to not take coverage. Employee-only insurance in 2016 for vision would go up $1 and a penny a month. Employee plus spouse would go up $2.13. Employee plus children would go up $1.87 a month. And employee family would go up $2.94 months on a 12-month pay.
Okay, so you've heard the proposal, the recommendation for vision rates to be increased, those amounts that you see on that piece of paper there, and we have 3,700 people in the as vision enrollees.
Right.
So it's still a fairly large number are participating. Questions, or is anyone ready to make a motion? Mrs. Barnes moves approval. Do we have a second? Second, was that Ms. Hickerson? Okay, any further discussion? If there's no further discussion, then all of you in favor of that, please say aye. Aye. Any opposed? Thank you very much. 2016 medical insurance rates.
Anybody feel like they need to stand up and stretch before we start this conversation? Maybe a lengthy
This
one.
all been going too easy here so far now, I'm sure.
I think they were settling in for this one, so. I've given you a couple of pieces of resource information in front of you, and then we have some color copies, which will really be the meat of our discussion today. The first sheet that you have is plan changes, and you know, a lot of times we come in, much as we have today, and we move through information fairly rapidly, and I wanted to give you an overview of 2011 forward of what we've done in terms of managing our plans, which impacts premiums and claims dollars. And if you look at this, we've done a lot. We've added, we've improved things where we were required to do by the ACA. We've taken away plans that weren't performing well. We've put new plans in place. We've made a lot of decisions to help improve the experience for the employees and control the cost as well. And so this document is just for your information only and to serve as a reminder of the things that we have done in the past. Now, when we started to look at our plans this year and start the premium discussion, we always look at what are we offering the employees and where could we potentially make some changes. So the next sheet that you have is possible plan changes that we investigated as part of our review for the premium increase for 2016. On the deductible plan, we looked at increasing the family deductible. We looked at increasing the individual out-of-pocket. And you will see that number 3 under the deductible plan, by basically worsening the plan for the employee by causing more cost sharing on their end, we would realize a savings of 1.89% to the budget, which in the grand scheme of our budget isn't a whole lot of money. But it is a whole lot of money to an employee that gets a rate increase and then shows up at the doctor and realizes that they have a higher deductible now, because that's the experience they're going to remember. We also looked at the copay plan, and we looked at increasing the copay from $30 to $35, and as you can see, that realized an extremely small percentage of savings to the overall budget. Now, one of the things that I do hear about the HRA is about the pharmacy, and it can be a gatekeeper for some people to take into HRA plan because their pharmacy costs could be very high and they can't fund the out-of-pocket cost as quickly as they could incur it. So we looked at potentially increasing the pay for the prescription cost at the window for the employee, but when we did that, by just raising the percentages ever so slightly, it contributed 2.81% to the budget, which is too much. So after consideration of these things, it's our recommendation that we leave our plans as is for 2016. And we proceeded along that path in terms of setting premiums for our 3 programs that we offer. Of course, we are always open to recommendations and suggestions, and anything that you have today, we will be glad to investigate, review, and report back on. This is a collective recommendation of both my experience, background, as well as that of Mr. Brown and others in his office as well. The enrollment history I provided to you last month. This is just a resource document to you, and it also shows to demonstrate what Mr. Brown said earlier, which is we have roughly 30% of our population in each of the 3 plans. Last year, as I said last month, the HRA plan, we saw it outpace the others by 4 points, with the deductible plan being the second with the highest enrollment, followed by the copay plan. The last document, or the next document for you on the legal paper, I wanted to provide you with a rate increase history. And if I went further back, you would probably be surprised at some of the rate increases that we did or didn't take and what the county absorbed in lieu of passing it on to the employees. And of course, that was during the period of collective bargaining, and I understand that sometimes we substituted benefits for pay, and those type of decisions had to be made, and decisions were made the best they were in light of the information available. If you'll look at 2011 forward, you will see that for the option 1, we actually dropped the $250 deductible plan, and we picked up the copay plan in 2013, resulting in a reduction in the overall premiums for the employees. And then we took 2014, we took a rate increase, which we all remember that was a very painful year. And then in 2015, you'll see these numbers, which are slight increases. The low number is contributed directly to the blending of the pre-65s, because we really had a 0% increase to the budget, but we had an impact to the total rate as a result of absorbing the $1.5 million to the active rate system to subsidize the pre-65s. And then we had the reduction in the 1%. And so that's where you see these increases coming from. And you can see the same for the deductible plan, as well as the HRA is broken out for you in the same fashion. So if you'd like to look back on those, I think that it gives a good picture of what we have done. The last sheet that I'm giving you as a resource is the average claim cost per employee per month by classification. We've broken this out. I went in and pulled Cigna's reports that they provided me the last annual reporting period, looked at those, and then I'll use the underwriting information that was provided for the premiums, which we will present to you, and broke it out by classified, certified, and county general, and showed you by copay, deductible, and HRA how we trend on a average claim cost per employee per month. And as Mr. Brown said earlier, the HRA shows not only the lowest premium, but it also shows the lowest claims trend as well. So moving on to the rates discussion. We've provided you with what you have seen traditionally, which is the colored copy premium proposals. And what I noted over the last 2 years is we did a lot of flopping around between page 1, page 2, page 3, and it was a little difficult at times to make sure we were all on the same page number. So I've done a cover sheet this time, and I've put 3 options out there for you. So let's talk about what those options are. And I apologize, I know the font is small. I did enroll in Vision. I've not used it yet, but I think this may be the year. Option A. Option A before you is current plan design, the necessary increase to the overall budget that we need to take based on expected claims trend, enrollment, and other factors we use in determining rates, and a 1% reduction to overall contribution. You can see that for an employee monthly increase on the copay plan, it would go up $6.87, followed by employee plus spouse of $32.44, employee plus child $28.57, employee plus family of $44.79. The column next to that will show you the direct impact of the 1% reduction in contribution. So as an example, for employee plus spouse, there's a monthly increase of $32.44. Again, this is based on 12-month deductions. But the impact of the 1% is $12.22 of that $32.44. So that's how you interpret this sheet. If you'll look at the orange box, what does it mean to get the budget to where it needs to be, keep the plans the same, and lower county contribution by 1%? It would mean that employees would pay an additional $1,330,302.11 out of pocket next year in terms of premiums. The county would pay $6,357,700.26 more in premium. The blue box shows you that the overall increase to budget need is 13.4%, keeping everything the same. Option B in front of you gives you current plan design, the necessary increase to budget, the 1% reduction in contribution, and a spousal carve-out. Spousal carve-out would mean that if you currently carry employee plus spouse coverage and your spouse works somewhere where insurance is offered to them, your spouse must go to their employer's insurance plan. Under the Affordable Care Act, we are required by law to provide insurance to our employee and their children. So therefore, we would be following the law in terms of requiring employed spouses who have coverage available through a group health plan to be required to take that health plan coverage. What does that do? If we were to adopt that, the overall premiums, which would come out of the employee's pocket, would drop from $1,330,302 next year to $359,794. The county's portion would drop from $6,357,700 to $125,305. There's significant savings there, both for the employees and for the employer. I want to remind you that we subsidize our plans. So the copay plan is not a fully funded standalone plan. The deductible plan is not a fully funded, nor is the HRA. We do a premium pool, and then we pay all of our claims regardless of the plan out of that. So when we set budget and premiums, we are also looking at it from that perspective. If we did individual pricing by plan design, these premiums would look very different. Also, employees are already subsidizing for the pre-65 retirees. Those individuals whose spouses already take their employer-offered insurance is subsidizing for our other spouses who elect to stay on the county insurance, who could obtain insurance through their employer. Our single employees are subsidizing for those spouses who have insurance available through their employer currently as well, because our claims dollars and our claims payments show that we average just slightly under $5,000 a year in claims costs per employee. We also average the same amount on a per year basis of the spouse's claims dollars. One other thing to look at as well is that the option C. If you move to option C, this is the defined contribution plan. On the defined contribution plan, as you could see in the survey that Mr. Brown provided, it's not uncommon to elect an amount that the employer pays, and then if you want to buy up to another option. Now, I'm not particularly advocating for this option. It is very unfriendly to the employee. It would be a substantial rate increase for them. But I wanted to give you this for education and demonstration purposes, and if it is the wishes of the committee, then certainly we'll pursue this. But the way that this would work is we know that the HRA plan provides the lowest premium, lowest claims dollars because it's a consumer-driven plan. So using the model that we will fund what the county contribution is for the HRA at current level minus the 1%, and we will fund that same amount for the copay and the deductible plan, it would look like this. The HRA plan for employee individual, the total monthly premium is $422.09. The county pays 100% of that. The premium needs for the copay plan on an employee individual for 2016 is $581.92. Using a defined contribution model, the employee would be responsible for paying the difference between $581.92 and $422.09 for a monthly premium increase of $108.52. And you would apply that same model to employee plus spouse, employee plus child, and employee plus family. And you can see that the rate increases on a per monthly basis would increase substantially under a defined contribution model. As an example, on employee plus family on the deductible plan, that monthly premium, because this just reflects the increase, would be somewhere around $800 a month for an employee. So I'd like to begin discussion of option A, B, and C, and to glean a better understanding of which of the options seems desirable to the committee. And once we discuss the options and which one we feel may be the most viable for 2016, the supporting detail behind those is included in these documents here as well. So as you're reviewing and considering the things I've just said, I'll explain to you what page 1, 2, and 3 is. Page 1 is just your baseline. It shows the needed increase to make budget at our current 2015 contribution levels. Now, we know we've already approved for the 1% decrease every year, but we like to provide you that baseline document. Page 2 gives you what was described in option A, the needed increase to meet budget, and the 1% reduction in contribution by the county. Page 3 coincides with option B. It gives you the current plan design, the needed increase for budget, the 1% reduction in contribution, and the spousal opt-out. And then page 4 coincides with the defined contribution model that we just talked about under option C. One more time. Option 1 is your baseline. It's current 2015 contributions with the necessary increase to make budget for 2016.
And this is all highlighted at the top where it says 2016 premium proposals, then there's yellow highlighted. So that kind of says what Ms. Street's saying, and then the page number's over in the far, so like.
Here. So if you look right under the 2016, there's this yellow line with small print in it. If you can read that, it will tell you. So page 2 coincides with option A. Page 3 coincides with option B. Page 4, I'm sorry. And page 5 coincides with option C. Is that right? Did I say it wrong first time? I'm sorry. I had 2 pages stuck together. I know. I apologize. One more time correctly. Okay. All right. Page 1 is your baseline. It doesn't relate to anything on this. Okay? It's just budget as is, current contribution.
Page 3 is spousal, no 1%.
Right. But page 2 is option A. We haven't gotten there yet. Right.
I'm saying page 3 is irrelevant.
Okay. Page 2 is option A. Okay. Page 4 is option B.
What about page 3?
Page 3 is irrelevant, he just said.
Page 3 is the spousal opt-out minus, not including the 1% to the employer.
Correct.
Okay.
So the only difference between 3 and 4 is that 1% change in the employee contribution.
Which we know we've already passed and have to do, so you can set 3 aside. That's what threw me off earlier,
Okay.
too. Page 4, are we caught up now? B, and 5 is C.
Okay.
Ms. Kreis.
I noticed that we've been trending 2.3% increase this year. And I know that we have to decrease the county's contribution by 1%, but I'm having a hard time understanding why we have to increase it 10 or 13% if we're only trending 2.3%.
Right. So the reporting that we do is on a fiscal year. So when you look at the Fund 264, that is a 7/1 to 6/30 period. When we set rates, because our fiscal year is a 7/1, our look-back period is different than the reporting period that you have. So when we look at what those claims are, we add medical trend, we add a lag period, which includes the time in which you're incurring costs, but the claims haven't actually presented at Cigna yet, and we accumulate that information. That's how we derive at what the necessary increase is.
And so the trend, so essentially what we're saying is you're looking at claims almost a year behind, and you're trying to project what you think the claims are going to be a year from now. And so the healthcare companies have a trend factor they apply, and that trend number is anywhere from 8 to 10%, depending on the months that we're looking. And so if you say we've increased our utilization 2 or 3 points, and then we have to apply a 8 to 10% trend, then we're kind of right around this 13%, 13.4% number that we're looking at. And that's because we're starting the process, and we started in February. It's 1st of April now, but it's projecting something in 2016. So.
I've got a question about this option B, the spousal carve-out. Inform me on that more or less. How do you enforce that? Is that on an honor system? We got to go out and check on every spouse's employer? And also, is there anything to do with the level of insurance that's available through an employer? An employer could have a very poor plan. It's basically next to nothing. And does that count? And I just wonder how we would facilitate that if we did go with that option.
Okay, so a couple of points. One is the first year, so this open enrollment period, we would use the honor system. And we would have an attestation on the open enrollment system that says something to the effect of, by electing employee plus spouse or family coverage, you're verifying that your spouse is not employed by a company or not employed by a company which offers group health insurance, right? The next year, we would actually use a formal process of verification, which is what a lot of companies do. Typically, it's a form that the employee has to take to their HR department or their insurance department and get it signed and validated that coverage is not offered through that employer. We sign them for people all the time. In terms of, and we are also due for another dependent audit process, so the timing of that would be good as well. In terms of the coverage level, that's typically not a relevant factor. Just because we are saying that if your spouse has employer-offered coverage available, we are not saying that your spouse has to take that employer-offered coverage. That spouse may be better off to go to the market. They may be better off to go to their local insurance agent and obtain a policy. We are just saying that because there is an opportunity for them to obtain insurance coverage through their employer, then by law we're required to only provide insurance for you and your children, and that is what we are making the decision to do.
And there are plans. Essentially, due to healthcare reform, you are required as an employer to offer a certain level of coverage to your employees. So, if we really got into the details, we would say it would have to be a certified minimum essential plan. But, that could still be a pretty high deductible option.
Okay.
We have a hole in the table.
Just a question on that. How much would the premium be if you dropped down from the family plan down in the new rate? If you did that plan, how much would the premium drop down for the employee to where they could apply that and say, well, if my employee portion at my wife's work or my husband's work is only $75 or $100 or whatever basic, that could pick that back up possibly where it wouldn't cost and they'd still get that minimum cover. You know what I'm asking?
Yes, I do. So if you will go, let's look at the deductible plan. If you'll go to your page 4, it will give you what those rates look like. So let's go deductible because that's always the highest cost plan, and everything else that's great comparatively. As an example, for an employee who would currently be in employee plus spouse, their premium would go from $205.12 to $65.12. If they had family coverage, it would go from $283.25 to $180.70. So there's substantial savings there. And typically you find that individual coverage runs less than $100 for that employee, and in a lot of situations it's free, just like with our HRA option.
Let's repeat. Let's go back. Did you follow that, Mr. Hall? Okay, I did not.
Okay. So if you will look at page 4.
Page 4.
Right, all the way to the left.
Deductible plan.
Deductible plan. If they are currently enrolled in employee plus spouse and their spouse works, then they would move from the employee plus spouse to an employee and an individual model. If we left the employee plus spouse in place for 2016, their premium would move from $173 in 2015 to $205.12 in 2016.
Okay.
But because their spouse works and has insurance available from their employer, they're going to go on that employer's plan. Now, our employee will drop down to employee-only coverage and pay $65.12 a month. Likewise, if they are employee plus family in 2015, their current premium is $239.40. In 2016, it would move to $283.25. Once the spouse goes on their employer's insurance, that premium would drop down to $180.70, so that the employee plus their children could remain on Rutherford County's plan.
Hey, I even followed that time, so thank you. Mrs. Nolan?
A point that the other employers have to follow the same Affordable Care Act provisions as well by providing health care that is affordable and...
That's correct. The Affordable Care Act applies to all groups over, it would be over 50, right? That would have to follow it.
It was just a point that when somebody goes to their employer, they also have to provide coverage that is affordable.
Correct.
Stevenson?
Would this only be applied to the active employee population, or would the pre-65s be held to the same plan?
The recommendation is that it's only provided for the actives, and for this reason. That pre-65 retiree is already at a reduced income level. They have planned for that retirement benefit as part of their overall financial planning, and therefore our recommendation would be to enact it with the actives. If you will look at, even on page 4 as an example, our greatest enrollment in the pre-65 is single coverage. There aren't a lot of spouses in that pre-65 retiree population to date. You could make the assumption that we have 16, 17, 18, that we have 35 spouses currently that are pre-65. So one fact that I was going to share with you is, that's what I just pulled out. One fact I wanted to share with you is, what does this do in the greater, 2016 and beyond, right, 2016 and beyond. Currently, as of 1/1/2014, and this is based on an actuarial study, our current liability for spouses of current retirees is $9.8 million. For spouses for future retirees, so active employees today who spouses would become retiree covered spouses, right? $29.9 million. So we're facing a much bigger issue than just what do we do about 2016. There is long-standing liability issues that need to be considered in this review as well. Ms. Hickerson, sir.
Ms. Hickerson.
I got a couple of questions here. The first one I wrote down early on is, if we do the spouse carve-out, how does that affect the OPEB dollars? That's what she just said. That would pull 29 million off. Okay. Now, with that being said, 2 other questions. When are we wanting these? I know they have 30 days once we tell them they don't have insurance to be on the other employer's insurance. So would that all occur that they would have to have, the spouse have to have his employer's insurance by 1/1/2016? And the second one is, can you touch base if we force them off? If a spouse, for example, my spouse is older than me, so he's probably going to get to retire before me. So, and his company would not offer retiree insurance. We have things in place of so many years on and so much work time, and all of that being said, tell me how, if he goes off on his insurance, what is the time frame that he needs to be back on? Since, I'm 20 years that he's always been on my health plan here, that once we retire, because I'll be able to keep it, that he can come back on and stay, or if he's still working and I retire, can I put him on? And
so
how does that work, please?
Let me walk through a couple of things. The $29.9 million, it wouldn't completely erase all of that liability, because you have some spouses that don't work, right, that stay on it. Secondly, once a spouse loses coverage available, even if our employee is a retiree under federal law, they still had 30 days to come back on our insurance plan. So in your situation, you're retired, he continues to work, then he quits working, he's got 30 days to come on our insurance, okay? What we are not doing by allowing spouses to stay on for 20 years when there is insurance available elsewhere is we are not making them eligible for their retiree insurance potentially because they may be the same situation as we are. So if your spouse works and their employer says you have to participate on our insurance for 10 years in order to get that retiree insurance, but yet they've always been on the county insurance because it's richer, cheaper, or whatever the issue is, then we've just removed their ability to take their insurance at retirement. So although we would not realize the total 29.9, and Ms. Nolan, tell me if you think I'm speaking out of turn on that, because we have spouses who will stay on because they don't work, we will realize a large portion of that. And even with the few that come back on, it's not expected that all would come back on for these reasons. One, they would qualify potentially for their employer's retirement. Two, they may discover there's a cheaper option out there as the market and everything else continues to evolve. And three, if they're like me, if I make it to retirement in Rutherford County, I get $500 a month. I can do whatever I want to with it. It is a defined contribution plan. I can either pay $500 towards whatever the premium is and pay the difference out of pocket. I can go somewhere else. So it really doesn't matter to me because, in terms of people in that classification, because it's $500 whether it's one person or you and your spouse, right? And so really 10 years and above, as of the cutoff date, that's really the only group of folks that would potentially have a spouse that would come back on based on the retirement language.
Other questions or discussion?
It would be effective January 1st. So your first question the good news is you guys do the renewal so early in the year, annual enrollment, that for the most part, we would be out having enrollment meetings before the spouses probably would. So they would know about this in advance of the other employer's annual enrollment, so they would have that time to make the decision during their enrollment period, and it would be effective January 1st.
Thank you for reminding me. I failed to answer that. One other thing, though, to point out on that I wanted to say is if they missed that open enrollment period and they didn't take it because they didn't realize that the spouse wasn't going to be eligible and so they were expecting to stay on ours, they would technically, by law, still have the 30 days after January 1 to retroactively go back to January 1 at their employer and pick it up, even if they missed their open enrollment period.
Mr. Hall had a question, but
so they would have if they miss it, then they could pick it up in January retroactively, as long as they did it within that 30-day period, and that onus would be on that employee and their spouse to make sure that they did that. That would be outside of us.
okay, Ms. Harvey?
Is it a general rule that if you're covered, like a spouse is covered, and then you have to go to the company that they're working for to pick up their insurance, and they have lots of medical problems, is it a guarantee that they would be accepted by that company insurance?
So under healthcare reform, they removed the pre-existing condition exclusion. So yes, they would be required to pick them up under the group health plan. Mr. Hall has another question, sir.
Mr. Hall?
That was kind of my question. I was just curious if we have a employee whose spouse is currently undergoing treatment for cancer or heart or something that's in and you drop them right here, do they, I say we cut them off or whatever it is that we're thinking about doing, it would immediately just change over, they change to a new plan, everything like that, or would we carry them through the end of their treatment and on that particular event?
So they would
switch them over, or would they just switch over and they switch to a new network and doctors and everything?
They would switch effective January 1. The adversity for the employee would be that they have the separate deductibles now. So you'd have to look at deductible versus premium to see if it'd be more cost effective or not. There is a chance that in that situation that the doctor they're going to now may not be in the same network as their company's employer's network. But as long as they're with the Blues, United, Cignas, Aetnas, there's a lot of overlay in those networks. So I don't know. I don't want to overstate that issue, but there is the potential for that to occur.
I haven't heard anyone ask any questions about option C. So is that just something that no one wishes to pursue any further to make our decision-making process, I guess, a little easier? So we're down to just option A and B, more or less, Ms. Harvey?
I have a question about option B. If you have claims, if the spouse has claims that does not get processed, say the doctor does not get the information to Cigna, are you expecting any gap there, problems there with paying those claims and getting all of that situated to make sure it's a smooth transition?
No, really, there's nothing unique about the fact of the spousal carve-out around that. If someone resigns from Rutherford County and they go to the doctor on their last day of employment, as long as their insurance was active that day, the claim will pay at Cigna through the period in which they were eligible.
Mrs. Barnes?
And I know you probably can't answer this specifically, but if we adopt this spousal carve-out option, we will see considerable savings with our premiums. What's your prediction for the next 2 or 3 years moving forward using this option? I mean, is that a fair question?
Mr. Brown may be able to answer it because he sees it in his book of business.
Yeah, I mean, the way we've looked at this over the last 2 years, I'm going to give a little bit of history and then answer your question. But I mean, essentially, as you can see, because I know we went through details in the examples, but take it back high level, we have a 13.4 needed increase of $8.3 million. And so we looked at, we could make some very major plan design changes to accommodate, to get somewhere close to there. We could pass on a lot of the cost onto the employees, even, and say, if your spouse, everybody, whether your spouse has coverage or not, everybody just gets a big rate increase. But what we've really seen a lot of employers do is go to this option. And the reason being is that we're saying the plan design staying exactly the same. The cost to the employees isn't going up that much more, not considering the other option. But what it's saying is if your spouse has other coverage available, they're required to take that plan. And so now we're in April. A lot of employers did that this past 1/1. A lot did it last year. So the backlash that we've seen from that is very little, because when they actually go home and they sit down and they look at their employer plan and they look at this one, they either come out pretty close to a wash or they actually save money. As we said, is that usually their employer plan for employee-only coverage, when you add that to what ours would be for that other difference, is less than what they're paying today. The negative is you have 2 ID cards. You've got 2 different plans to deal with. Where do you put the kids? A lot of times what people find out is the other plan might be a little better. A lot of people we had go to the marketplace. So what we're doing today is, as we said a second ago, is by offering the spouse plan, it makes it very hard for the spouse to go out to the marketplace and get a subsidy and find a plan available. By not offering it to them, that's another option they may pursue that does help later on when you get the pre-65, because we had very few people take that option this year of giving them the $500. I think there's 2. 2 people took that option, but as you start kind of getting them used to looking at their options available, you'll see more people do that. It'll help our long-term liability, and it gives them more choice. But as we said, now to answer your question, what we've seen is the spouse generates just as much claims as the employee. So in theory, if we're only projecting, just so you know, we haven't said this yet, we're only projecting 30% of the spouses to leave, and that's generating this overall 1.5% increase. So we're going from 13.4 to 1.5, from 8.3 million to a little less than 1 million. So, and that's with 30%. Some of our estimates are saying this could be as much as 50%, which would be a significant reduction. And so to the point, every spouse that comes off the plan goes to get coverage at their employer is going to definitely help us in the future years, because kind of what we're seeing now is all the spouses are coming onto our plan. Their employers' deductibles are going up, their costs are going up, and ours aren't. So everybody's hopping on our plan, which is causing our increases. If you look at that 5-year history, we had 2 bad years, 1 good year, bad year, and it's largely due to the spouses. So I'm very hopeful. One, my estimate's low and it's not 30, it's 50. That's going to make next year great. And if we get 50% of the spouses off paying the same amount of claims as the employee, those two things together should help us for the next couple of years.
Just a couple more pieces of information for you all. We calculated a little under 2,500 spouses on the plan. I also went through, and with the help of Ms. Nolan going through the blinding process of scrubbing Excel spreadsheets, and we learned that just under 500 people are married to each other. So 250 couples, a little under 500 employees. So they have a spouse that works in the county, right? So that leaves about 2,000 people that we're looking at. Our spouses, using the numbers on an annual basis, based on last reporting from Cigna, our employees were at $4,393 per year in claims, is what we saw on average. The spouses were actually at $4,785 per spouse during that year. If you take the 2,500 spouses multiplied by the 4,785, that's $9,570,000. If you carve out the 500 that we know are married, and they could have single, they could have employee plus spouse, you're still looking at millions of dollars that potentially, and that's just the claim side. That doesn't count the premium contribution that we make for those spouses.
Okay, Mr. Jordan has the mic in his hand.
Well, I hate to ever do anything that reduces what we're giving or supplying for the employees, but, the reality is health insurance, health care is a beast that we've got to fight every year, and some years are more painful than others. If we can take this is one time Obamacare may actually be helping us. I can't believe it's the only time I've ever had this opportunity to say that. But by them having to take a person with pre-existing conditions onto whatever policy, and employers having to offer a policy, this potential of up to $29 million in long-term liability, those numbers are the ones that are going to come back and get us, those OPED numbers. 20 years from now, whoever's sitting up here is going to be in a world of hurt if we don't make more and more of these tough decisions. And so with that, I'll make a motion we go with option B.
Second from Ms. Hickerson. Okay. Any other discussion? Seems a pretty obvious decision, doesn't it? All right, then, all of you in favor of this, please say aye. Aye. And Ms. Nolan, just excuse me, any opposed? Let it reflect it was unanimous, Ms. Sherry. Ms. Nolan?
I just had a question just to follow up. You said you've got other businesses that have already done this. How do they handle the children? If both spouses work, are there, it seemed like back in the day it's like whoever's birthday the kids were closest to, they were the ones who had to carry the kids. No, that's what I did at the state as well. Yeah, so I just didn't know what do you see?
Typically, we do see in that instance, you look and try to figure out what plan makes the most sense, what cost is less. I'm going to assume, because of the numbers we've seen in the contribution strategy, that it's going to make sense financially for the children to stay on this plan, just because we know the contribution says your contributions are better than the average. So I believe in most instances they're going to stay here. They can do double coverage, but your children are your ones with the lower claim utilization, so why would you pay twice? So I think they would stay here.
Yeah, well, I would think that too, but I didn't know if there were rules that says if
have to go one or the other. There's no rules.
If both employees are spouses, though, they can cross cover by law.
If both employees or if both boys work here, Are you saying if both employees work here or just in general? Yeah, in general, there's no rules. Yeah. Right.
I'm just going back in the back when it seemed like my husband and I both had coverage. We both covered the kids, but really, it's whose ever birthday the kids.
Yeah, that would be if you have double coverage. It's whoever's birthday pays first and the other pays second. But typically now, nobody has the double coverage, so you do get to decide, do you want them to stay here or there? There's no rules that makes you, right.
I was getting to, there's no rules.
No rule that picks it for you, right.
Ms. Stevenson.
I have one question. On the, each of the options, the enrollment, is that actual or projected?
That is actual based on current enrollment numbers.
But the spousal opt-out is projected based on
Okay,
30%
that's what I was
of
wondering,
the
because
people
that was the
coming
one
off.
that was different.
Right.
A and C was different from B, and I was like, why is that different? Okay.
30% is what they've assumed would. Ms. Harvey?
Follow-up question. After it gets through here at this committee, this will go to the commissioners.
Goes to Budget Committee
Budget,
first.
and then the commissioners. And then once they agree or disagree, if they agree, how soon will the employees know about this and the change that's going to be coming up? How are we going to get that information to them?
So we would go ahead, because to get in front of the open enrollment period for these spouses, we would go ahead and make a notice out to employees to let them know. Now, we would probably do it through email unless it's decided that we need to do a special mailing to employees to let them know that this is coming. And then again, it would be discussed in all of our open enrollment meetings that we had this year, as well as included in the open enrollment packets. Typically, open enrollment occurs for most groups, and tell me what you see, but somewhere around the October, November time frame. We send out our packets of information in September, and we start meetings in September. So from an employer perspective, we're normally ahead of the curve anyway in those regards, so they should know well in advance.
And we're trying to do, in the past, I mean, it's been 5 years since we've had mandatory meetings. We are leaning towards making the recommendation to do mandatory meetings this year, just to make sure this message gets out and we're not having those issues in January, February, where people may have missed the deadline. So we are wanting to do that as well.
Ms. Hickerson?
Okay, I have two questions again. The first one is actually a statement, just kind of to put it out because it is on TV. The changes that we are making of the spouse carve-out affects only active employees, period. No pre-65 retirees or the post and the grandfathered. It's active employee only.
That's correct.
Okay, and then the next one, we were talking about doing a special mail out. Would we be required to send a letter of credible coverage to the spouse of the employee to be able for him or her to take to their employer and say, we've had insurance, they just kicked me off. Thank you. You need to pick me up.
We're not required to send that. We do get requests for those even today, and we have a letter that we produce and send out to those individuals. And it would be difficult for us to know at open enrollment whether or not they just dropped it because they would have dropped it anyway, or if they dropped it because of this, so we could provide that letter upon request.
Go back to Mrs. Harvey's question. I mean, if we take this on the budget in April, it would be at the commission in April. Are we going to go ahead and do at least the initial notice after that commission meeting?
We would want to get the initial notice out prior to the end of the school year in order to have majority of the teachers notified before the summer months begin.
Okay, any other business to come before this committee today? Okay, if not, then we are adjourned. Thank you.